Hi, this is Brent Betts. I wanted to present a case of a full thickness cornea transplant or penetrating keratoplasty. There are approximately 22,000 of these performed every year in the United States. The eye in this case has keratoconus, which is a progressive thinning disorder of the cornea where the shape of the cornea becomes warped. This patient failed contact lens and other medical therapies and desired vision improvement. I'm using low temperature cautery to flatten the central cornea. Eyes with keratoconus tend to have very steep cornea centrally. In order to cut the cornea off the eye, we use a circular blade called a trephine. When the cornea is very steep, it can be difficult to get a good cut, and this will lead to a substandard outcome. It's important to be gentle during this portion of the procedure as you can perforate the cornea, making the rest of the surgery more difficult. Once that's done, I measure the cornea, trying to find a size for a trephine or circular blade. And then we mark the corneal center. A well-centered cornea transplant is part of the vision recovery process. If corneas are decentered, sometimes they have to be due to infections or trauma, or where the scar is located, patients tend to have a substandard visual outcome. So take a lot of time setting up my corneal center mark, making sure that's exactly in the right spot. In this case, I'm using the 8.5 millimeter corneal trephine made by Moria. This trephine is a vacuum trephine, which allows me to center it on the previously made mark. I will keep this on the eye while I prep the donor graft and recheck it before I cut into the cornea. The donor cornea is centered on a punch. This one is 8.75 millimeters and also made by Moria. I use digital pressure to push down on the graft to cut it. I've preset the cutting depth on the trephine, and I will spin it in order to cut down to about 90% depth on the cornea. I use a marking pen in order to mark out where I'll place my sutures, and then the cornea is cut into with a 15-degree blade. The eye is filled with viscoelastic, and curved corneal scissors are used to remove the diseased cornea. You try to depress the scissors into the trephination track in order to have a uniform cut. Once the graft is removed, you try to work quickly in order to place the donor cornea. The first 4 sutures are called cardinal sutures and are important to place quickly in order to minimize complications of having a completely open eye. After the initial 4 sutures are placed, viscoelastic is re-injected into the eye. This allows us to see where the graft is located. Sometimes it's not perfectly centered, and so additional sutures can be placed in order to help center the graft better so that patients have a better visual outcome. Some penetrating keratoplasties are done with a running suture. This usually involves placing 8 to 12 interrupted sutures followed by a single suture that goes all the way around the cornea. In this case, I am doing 16 individual 10 nylon sutures. At this point in the case, I am removing viscoelastic from the anterior chamber by gently injecting balanced salt solution into the anterior chamber. This allows for lower eye pressure after the surgery is complete. Penetrating keratoplasties typically take 60 to 75 minutes to complete. The surgery is done under a regional block called a retrobulbar block, where the eye socket is anesthetized. Some cases are done under general anesthesia due to high risk for complications. Due to the small gauge of the sutures and the fact that they're all placed manually, it can be difficult to make exactly equal tension on every single suture. So sometimes there are loose ones that I'll remove or replace as I move forward through the surgery. Doing a penetrating keratoplasty is like learning to ski. You may have the basics down, you might be pretty good, but you're always looking for ways to improve your technique. Sutures that are too tight or too loose can delay graft recovery and visual recovery for patients. So it's important to take your time during this part of the procedure. For you to get an idea of what placing a suture is like, I'm showing this one completely unedited. Once this final suture was placed, I re-wet the eye and center it, and then I use a small ring of light we call a keratoscope to manually check the astigmatism. In this case, I replaced 3 sutures which were overly tight. All of the suture knots are rotated into the cornea itself. The cornea has more sensory nerve endings per square millimeter than any part of the body. So if there's an unrotated knot, the patient knows immediately, and it can be extremely uncomfortable. Sometimes they do unrotate on the day after surgery, and they can be rotated back into the eye at this lamp. Now I'm smashing down with a Wexel sponge on the graft-host junction to make sure there are no leaks, and also to ensure that there is good approximation between the donor tissue and the host corneal tissue. This ensures that the wounds will heal properly. I selectively remove sutures 3 to 4 months after the surgery is performed, and then remove only enough sutures to minimize astigmatism to help with the patient's vision recovery. Thanks for watching my video. Please subscribe for more surgical videos.